been here for many years, and prior to being here was in Chicago at Children's Memorial. He is I don't want to say a founding father because Dr. Nadich, it ages you, but has really helped build the field of pediatric neuroradiology and is a mentor to many successful neuroradiologists and neurosurgeons, frankly. So he's going to give us an introduction on the radiology and pathology of colloid cysts, and then we'll continue on with our other presentations.
Okay. Can you see the screen?
Looks great.
Okay. All right. Colloid cysts are developmental cysts of the ependymal pouch of the diencephalon. They typically attach at the anterior end of the velum interpositum or the third ventricular choroid. The cyst wall is cuboidal, low columnar epithelium, resting on a collagenous base. The appearance is highly variable. This was an 8-year-old child found dead on the sidewalks of New York decades ago. I was in the medical examiners, and you can see the hydrocephalus and the grape of the colloid cyst obstructing the foramina of Monro. The colloid cysts are an epithelium of interspersed ciliated and goblet cells resting on this collagenous membrane. They secrete a fluid that is analogous to mucus from respiratory epithelium. As you know, mucus can be watery or inspissated and dried. That influences the appearance of the colloid cyst on imaging. Here, for example, you can see the cyst, but there are different areas of dried out and more watery mucus in the cyst. Typically, you find the colloid cyst as a round 1 to 3 centimeter lesion at the foramina of Monro. This is the fornix coming around to the retro-anterior commissural zone onto the mammillary body. Here is the stria medullaris at the roof of the third. This is the velum transversum, and just at the anterior end of the third ventricle region of the foramina Monro, we have a lesion that is sharply marginated and bright white and is a colloid cyst. When different areas become inspissated, we have inhomogeneous appearance of the colloid cyst. That results in what's called the black hole sign of a colloid cyst, with the inspissated center and the more watery surround. The colloid cyst may elevate the septum pellucidum, obstruct both foramina of Monro, and it is important in imaging to look for any patient with hydrocephalus to see if the fornices are normal or if instead of fornices, you see a colloid cyst. Typically, they elevate the fornix, so the fornix comes over and does a jig atop the colloid cyst. You may not see it or appreciate it on T1 imaging. You need the T2 to see it for sure. They are not always at the foramen of Monro. In this case from Sinai, there was a mass with the fornix above and the roof of the third below that was in the cistern of the velum interpositum, but further posteriorly. The approach was not to Monro, but it was lateral under the fornix at the mid-ventricular body. And this is what was found. Colloid cysts may have a mimic. Please, before you apply the knife, double check it's not an aneurysm of the tip of the basilar artery. They are also found at other sites. You think of a single one, but they may be multiple. Here is a colloid cyst of the fourth ventricle proved pathologically. Not common, but definitely well known. This is a patient with multiple colloid cysts. The preoperative MRI shows two cysts in the third ventricle and a third cyst in the lateral ventricle. At surgery, they opened the cyst in the lateral ventricle, exposing the content, drained it, removed the deep wall, and showed the more anterior cyst in the third ventricle, resected that, showed the cyst in the posterior third ventricle, and then exposed the fornix and Monroe. Thank you very much.
Thank you, Dr. Nadich. I think that seeing the pathologic next to the radiologic is extremely useful for these, and you point out a lot of things that are very important for surgical planning and consideration for these patients. Does anyone have any questions before we move on? Okay, so I'll give brief introductions. I always